Assalamu alaikum everyone. Bismillahir Rahmanir Rahim. Quote of the day: Success is not final, failure is not fatal. It is the courage to continue that counts. I am Dr. Hussain Mahmood, PGR from Community Medicine. Today I am presenting on tuberculosis under kind supervision of Professor Dr. Sarah Afzal. Learning outline. Introduction, epidemiological triad, chain of transmission, clinical features, prevention, WHO response, TB control program in Pakistan, recent updates, and MCQs. Learning outcomes. By the end of this presentation, participants will be able to describe the epidemiological triads, chain of transmission, clinical features, prevention, WHO response, TB control program in Pakistan. Introduction of TB. Tuberculosis is a bacterial infection spread through inhaling tiny droplets from the cough or sneeze of an infected person. It mainly affects the lungs, but it can affect any part of the body, including the tummy, glands, bones, and nervous system. The World TB Day celebrated on March 24. Examples of epidemiological triad. For TB, this is a model of agent in the TB bacterium. Host factor include non-immune, weakened resistance, poor nutrition, and environmental factors include crowded condition, poor ventilation, and bad sanitation. Incubation period. The time from onset of infection to the development of positive tuberculin test ranges from 3 to 6 weeks. The development of disease depends upon the closeness of contact, extent of disease, and sputum positivity of the source case, and the host-parasite relationship. Thus, the incubation period may be weeks, months, or years. Period of communicability. Bacilli survive in droplet for 8 to 10 days. Patients are infective as long as they remain untreated. Portal of entry. Commonest point of entry: nose, throat, and mouth. The classification of TB. Permanent TB also classified as a primary disease and secondary disease. Extrapermanent TB classified as a lymph node TB, pleural TB, TB of upper airways, skeletal TB, genitourinary TB, miliary TB, pericardial TB, gastrointestinal TB, tuberculosis, meningitis. Primary TB. Primary TB is characterized by the Gone complex and consists of subpleural focus of inflammation, infected lymph node draining the primary subpleural lesions. Secondary primary TB is characterized by a focus of infection and granuloma formation, usually in the apex of the lung. The small granuloma externally collapses to the form larger area of consolidation with central sysgetic necrosis. Regional lymph node contains sysgetic granulomas. Progressive TB, primary secondary TB may go on to heal, and sysgetic granulomas are replaced by fibrosis and calcification. However, cases don't heal spontaneously or with therapy to progress and create cavities are spread to the other part of the lung and other organ of the body through lymphatic channel and bloodstream. This type of spread is known as miliary tuberculosis. How TB spread? TB spread through the air. TB spread from person to person when someone with contagious TB coughs, speaks, or signs. Latent TB infection and TB disease. Latent TB infection, people with latent TB infection don't feel sick, don't have symptoms, and cannot spread TB germs to others. Can have latent TB infection for years, have a small amount of TB germs in their bodies that are alive but inactive. Latent TB infection can develop into TB disease. TB disease, if TB germs become active and multiply, latent TB infection can turn into TB disease. Person with latent TB infection has a small amount of TB germs in his or her body that are alive but inactive. Patient with TB disease has a large amount of active TB germs in her body. Patient with latent TB infection cannot spread TB germs to others. Patient with TB disease may spread TB germs to other. Patient with latent TB infection does not feel sick but may become sick if the germ become active in her body. Patient with TB disease may feel sick and may have symptoms such as cough, fever, and weight loss. Patients with latent TB infection usually have positive TB skin tests or TB blood test result indicating TB infection. Person with TB disease usually has a positive TB skin test or TB test result indicating TB infection. Person with latent TB infection should consider treatment for latent TB infection or prevent TB disease. Patient with TB disease needs treatment for TB disease. Untreated latent TB infection can lead to TB disease. If the immune system can stop TB germ from growing, they become active. This is called TB disease. Most people diagnosed with TB disease became sick after living the latent TB infection for years. Latent TB infection treatment is 95% effective in preventing the development of TB disease. Possible TB disease symptoms are night sweats, fever, chills, weakness or fatigue, weight loss, low appetite, cough lasting longer than 3 weeks, pain in chest, coughing up to blood or sputum. Symptom: latent TB, a person with latent TB will have no symptom, no damage will show on a chest X-ray. However, a blood test, skin prick test will indicate they have TB infection. Active TB, an active with TB disease may experience a cough that produces phlegm, fatigue, a fever, chills, and loss of appetite and weight. Early warning sign. Early warning sign. A person should see a doctor if they experience a persistent cough lasting at least 3 weeks, phlegm, which may have blood in it when they cough, a loss of appetite and weight, a general feeling of fatigue and body being unwell, swelling in the neck, a fever, night sweat, and chest pain. Beyond the lung, the TB usually affects the lung through symptoms can develop other part of the body. This is more common in people with weakened immune system. TB can cause persistently swollen lymph node or swollen gland, abdominal pain, joint or bone pain, confusion, or persistent headache, seizures. Public health workers are responsible for finding TB contacts. A TB contact is a person exposed to someone with contagious TB disease. Contact can include family members, roommates, housemates, close friends, co-workers, classmates, and others. People with TB disease can spread TB germs to those around them. The local health department will conduct a contact investigation by following up to the testing those who have been close to someone with TB. Risk factor. Who is the higher risk for becoming infected with TB germs? Anyone can get TB. Some people have a higher risk of getting infection with TB. People who have contact with someone who has infection TB disease. People who were born in or who frequently travel to countries where TB disease is common, including Mexico, Philippines, Vietnam, India, China, Haiti, Guatemala, and other countries with high rates of TB. Healthcare workers and others who works or live in places at high risk of TB transmission, such as homeless shelters, jails, and nursing homes. Who is at risk for developing TB disease? People at high risk for developing TB disease generally fall into two categories. Those who have been recently infected with TB germs, those with medical conditions that weaken the immune system, such as HIV infection, substance abuse, specialized treatment for rheumatoid arthritis or Crohn's disease, organ transplant, heat or neck cancer, diabetes, medical treatment such as corticosteroids, liposis, low body weight. Complication without treatment of tuberculosis can fatal untreated active disease typically affect your lung, but it can affect other part of the body as well. Typical complication include spinal pain, joint damage, swelling of the membrane that cover your brain, liver or kidney problem, heart disease, like cardiac tamponade, TB testing. Two types of tests can be used to diagnose TB infection. The first is the blood test, then the TB skin test. The either test is positive, further test can done to confirm a diagnosis of TB disease, medical examination and chest X-ray. TB blood test. Blood is drawn and sent to a lab for analysis. Positive blood test, a person likely has been infected with the TB germ. Additional tests are needed to determine if the person has latent TB infection or TB disease. Negative blood test, a person blood did not react to blood test and latent TB infection or TB disease is not likely. The TB blood test is also known as interferon gamma release assay. TB skin test. The TB skin test, also called the Montauk's tuberculin test, requires to visit with the healthcare providers. On the first visit, the test is placed, and on the second visit, the test is read. Gene expert. The gene expert diagnoses TB by detecting the presence of TB bacteria. The test is molecular TB test. We detect the DNA in the TB bacteria. It uses the sputum sample and can give a result in less than 2 hours. The gene expert can also detect the gene mutation associated with resistance of drug rifampicin. Gene expert for drug-resistant TB. In July 2020, it was announced that the new test has been developed with which could detect resistance of both first-line and second-line drugs. This means that clinician can find out in 90 minutes which drug a patient is resistant to and prescribe the correct treatment for both MDR and XCR TB. People vaccinated with BCG can still get TB disease. Basically, Calumet Gorian BCG is a vaccine for TB disease. Is often given to infant and small children in countries where TB is more common. Protect against rare forms of TB in children. TB blood tests are preferred for people who have received the TB vaccine. The TB vaccine may make a TB skin test hard to interpret. The TB vaccine does not affect TB blood test result. TB blood tests give more accurate result in people who have received the TB vaccine. Treatment. The first-line treatment is isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. Polys is resistant to more than one drug, but not the combination isoniazid and rifampicin. MDR TB resistant isoniazid and rifampicin, two most potent TB drugs. Lack of efficacy, XDR TB resistant that respond to the events fewer available medicine include the most effective second-line anti-TB fluoroquinolone and second-line injectable amikacin, kanamycin or capreomycin. Second-line TB drugs are ethonamide, furosemide, cycloserine, trazodone, para-aminocyclic acid, and a novel generation of anti-TB, delamide, protamide, and betacholine. How is latent TB treated? If you have become infected by TB but no have active TB, you have got preventive therapy. This treatment kills germs that could cause problem if the disease become active. The most common preventive therapy is daily dose of antibiotic isoniazid taken as a single daily pill for 6 to 9 months. You are not contagious if you have latent TB. How is active TB treated? If you have an active TB, you will probably be treated with combination of antimicrobial antibacterial medication for a period of 6 to 12 months. The most common treatment for active TB is isoniazid in combination with the other drugs, rifampicin, pyrazinamide, and ethambutol. Drug-resistant TB means that some drugs essentially used to treat TB will no longer be able to fight the TB germs in your body. TB that is resistant is more than one drug called multi-drug resistant TB. The treatment for this type of TB takes much longer, 20 to 30 months to complete, meaning after managing of tuberculosis. You must finish your medicine and take the drug exactly as prescribed. While you are in treatment for active TB disease, you will need to regular checkup, make sure your treatment is working. Everyone is different, but there are side effects associated with taking the medication, includes upset stomach, nausea, vomiting, loss of appetite, tingling of numbness sensation, itchy skin, rashes, bruising, changes in your eyesight, blood vision, yellowish skin, eyes, dark colored urine, weakness, fatigue, and fever with 3 or more days. Vaccination. The vaccine, BCG vaccine efficacy is 0 to 80%. Valent use for BCG vaccine is normal saline. Should be given to all healthy infants as soon as possible after birth, unless the child presented with symptomatic HIV infection. The types of BCG vaccine, the liquid vaccine, and the freeze-dried vaccine. Freeze-dried vaccine is more stable preparation, stable for several weeks at ambient temperature in tropical climate and for up to 1 year if kept away from direct light and stored in cool environment, preferably refrigerated at temperature below 10 degrees centigrade. The dosage for vaccination, the usual strength is 0.1 mg in 0.1 ml volume. The dose of a newborn at below 4 weeks is 0.05 ml. Administration, the standard procedure recommended by WHO is injected to the vaccine endodermal using a tuberculin syringe. Phenomena after vaccination, 2 or 3 weeks after injection of potent vaccine, a papule develop reaches a diameter of about 4 to 8 mm in about 5 weeks. It then subsides, then covered with the crust. Healing occurs with 6 to 12 weeks, leaving a permanent tiny round scar, typically 4 to 8 millimeter in diameter. Complication of vaccines, severe ulcerations, portal lymphadenitis, osteoarthritis, disseminated BCG infection, death, protective values. The duration of protection is from 15 to 20 years. Contraindications generalize eczema, infective dermatitis, hypogammaglobulinemia, deficient immunity, suspected congenital immunodeficiency, generalized malignant disease, patient under immunosuppressive treatment, and pregnancy. Expanded program on immunization. This is the schedule for BCG in childhood TB. Directly observed therapy for the treatment of tuberculosis. National TB treatment guidelines strongly recommend using a patient-centered case management approach, including directly observed therapy when treating person with active TB. Dose is especially critical for patients with drug-resistant TB, HIV infected patient, and those on intermittent treatment regime 2 to 3 times weekly. That means that our trained healthcare workers or other designated individual provide the prescribed TB drugs and watches the patient swallow every dose. 5 components of that strategy. The first component, political will diagnosis by quality microscopy of sputum, adequate drug supply, directly absorbed therapy, treatment, accountability, symptomatic monitoring. The main advantage of DOTS are cure rates of up to 95%, prevention of MDR TB emergency, improvement of longevity of AIDS patient by TB control. It is one of the most cost-effective of all health intervention according to World Bank. WHO response. According to WHO response definition and the reporting framework for tuberculosis 2013 revision, case definition of bacteriological confirmed TB case is one from whom a biological spectrum specimen is positively by smear microscopy culture or such WRD such as expert MTB and RIF. Such case be notified regardless of whether TB treatment has started. A clinically diagnosed TB is one who does not fulfill the criteria for bacteriological confirmation but has been diagnosed with active TB by a clinician and other medical practitioner who has decided to give the patient full course of TB treatment. This definition includes case diagnosed on the basis of X-ray abnormalities or suggestive histology and extrapulmonary case without laboratory examination. Bacteriological confirmed or clinical diagnosed case of TB are also classified according to the anatomical site of disease, history of preventive treatment, drug resistant, HIV status. Classification based on anatomical site of disease is pulmonary tuberculosis and extrapulmonary tuberculosis. Classification based on HIV status, HIV positive TB patient referred to the bacteriological confirmed or clinical diagnosed case of TB who are positive. Result from HIV testing conducted as the time of TB diagnosis or the other documented evidence of involvement of HIV care. HIV negative TB patient referred to any bacteriological confirmed or clinical diagnosed case of TB who has a negative result from HIV testing conducted as the time of TB diagnosis. HIV status unknown TB patient refers to any bacteriologically confirmed or clinically diagnosed case of TB who has no result of HIV testing and no other documented evidence of involvement in HIV care. Classification based on drug resistance. In case of classified categories based on drug susceptibility tests are clinically isolated monoresistance, resistance to one first-line anti-TB drugs only, polydrug resistance, resistance to more than one drug, first-line anti-TB drugs, multi-drug resistance, resistance to at least both isoniazid and rifampicin, extensive drug resistance, resistance to any fluoroquinolones, and to at least one of 3 second-line injectable drugs. Rifampicin resistance resistant to the rifampicin detected using phenotype or genotype method. Classification based on the history of preventive TB treatment. A new patient has never been treated for TB, have taken anti-TB drugs less than 1 month. Previously treated patient has received 1 month more than TB drugs. Relapsed patient, treatment after failure patient, treatment after loss of follow-up patient, other previously treated patient with unknown previous TB disease history. This is the classification of TB, no TB exposure, not infected, then infected, clinically active TB, previously TB disease, and suspected TB. Multi-drug resistant TB, anti-TB medications, medicine have been used for decades, and strains that are resistant to other are more of the medicine have been documented in every country surveyed. Drug resistance emerges and when anti-TB medicine are used inappropriately. The trophic post global commitment and WHO response on 26 September 2018. United Nations held its first ever high-level meeting to TB, inviting a discussion about the status of TB and epidemic and how to end level of field heads or states and governments. Treatment for TB disease in pregnancy. Untreated tuberculosis disease represent a greater hazard to pregnancy women and her fetus. Adults is infants born with the woman untreated TB may be lower birth weight and those born without TB. Treatment for latent infection and pregnancy. For most pregnancy women, treatment for latent TB infection can be delayed until 2 to 3 months postpartum to avoid complications. TB treatment regime, latent TB infections, TB disease, and HIV-related disease treatment. Indications are streptomycin, kanamycin, amikacin, capreomycin. This is the end of TB strategy, the vision, the word-free tuberculosis goal, and the indicators. These are indicators and milestone and targets. These are given in this table. These are the pillars and components of TB. This is the tuberculosis profile. Tuberculosis profile shows 45% men, 41% women, and 14% children. 48% treatment coverage and 93% treatment source rate. Recent update, tuberculosis key fact, a total of 1.3 million people died from TB in 2022. Worldwide TB is second leading infection killer after COVID-19. In 2022, estimated 10.6 million people falling with tuberculosis worldwide, including 5.8 million men, 3.5 million women, and 1.3 million children. Global effort to combat TB have saved an estimated 75 million lives. Ending the TB epidemic by 2030 is among the health target of the United Nations Sustainable Development Goals. This article, published in 2024, a comprehensive review of long with short regime in multi-drug resistant tuberculosis under problematic management of drug resistant tuberculosis. This is article published in also 2024, a synthesis of qualitative evidence of barriers and facilitators in implementing guidelines for TB testing in healthcare settings. Now MCQs. MCQ tuberculosis is an infectious disease that mostly affects the lungs. The causative agent that cause tuberculosis are communicated from person to person via minute droplet discharge into the air by cough and sneeze, Clostridium difficile, Staphylococcus methicillin-resistant Streptococcus aureus, Mycobacterium tuberculosis, and Salmonella. It's D, Mycobacterium tuberculosis. Tuberculosis infection control is a sort of measurement designed to reduce the risk of transmission within ABC population. Mycobacterium tuberculosis can be transmitted through route airborne transmission, mite transmission, vector-borne transmission, oral transmission, and zoonotic transmission. It's A, airborne transmission. A patient A is a 30-year-old man who was admitted to the hospital from home after suffering from a week of coughing excessive nocturnal sweating, loss of appetite, and hyposmia. Osmia. The patient with a history of intravenous drug abuse and has been diagnosed with hepatitis B. Chest X-ray shows consolidation. The following is the most common cause of this condition: actinomycosis, aspergillosis, constrictive pericarditis, histoplasmosis, and tuberculosis.
E.
Yes, it's E, tuberculosis. When bacteria become resistant to drug used to treat TB, drug-resistant TB can develop drug resistance. Tuberculosis is transmitted in the same way the drug-susceptible TB is. This type of TB takes longer to treat, to take at least a month to complete the treatment. 9 months, 6 months, 3 months, 20 to 30 months, and 2 months. It's D, 20 to 30 months. When people live and work in crowded and poorly ventilated surroundings, tuberculosis can spread swiftly. Tuberculosis is 18 times more prevalent in those who are infected with common cold, diphtheria, giardiasis, HIV/AIDS, or infection mononucleosis.
D.
It's D, HIV/AIDS. The XYZ community patient with the relevant clinical manifestations such as cough lasting more than 2 weeks, lymphadenopathy, fever, night sweat, and weight loss are suspected for having pulmonary tuberculosis. People had received the tuberculosis vaccination in the past, which tests give more accurate result in people who have received the TB vaccine. Blood tests, bronchoalveolar lavage, chest X-ray, culture of sputum, and lung biopsy.
D.
It's A, blood test. When antibiotics were first introduced to treat tuberculosis in the 1940 and 1950, the number of cases in XYZ developing countries started to fall. Following, the number of TB cases began to climb again after 1985, which epidemic was the major contributor to the increase in tuberculosis infection in XYZ country after 1985. Ebola epidemic, HIV/AIDS epidemic, plague epidemic, yellow fever epidemic, and Zika virus epidemic.
B.
Yes, it's B. Patient XYZ is a 35-year-old man who was admitted to the hospital after experiencing a weak cough, profuse nocturnal sweating, loss of appetite, and hyposmia at home. Tuberculosis was diagnosed after he was seen by emergency room physician. Patient XYZ was prescribed isoniazid, rifampicin, pyrazinamide, and intubated 7 days a week for 8 weeks. Then isoniazid and rifampicin 7 days a week for 24 weeks. In the scenario, what will be the level of TB prevention, primordial, quaternary, secondary, and tertiary prevention? It's D, secondary prevention. A 39-year-old HIV positive man from Uganda have recently immigrated to the United States and being evaluated at the clinic. He was diagnosed HIV shortly after arriving in the United States. He's asymptomatic and interferon gamma release assay is ordered as a part of this initial evaluation to check the latest tuberculosis infection. The result come back to the negative after few days. Short patient blood did not react to the test and TB disease is not likely. She had Mycobacterium tuberculosis for an infectious indefinite period. It's A, patient blood did not react to the test and TB disease not likely. Consequent patient care of care tuberculosis testing, including testing people admitted to hospital, testing people at a peripheral clinic, and testing people in a community setting are at home. Which of the following technologies is suitable for point of care testing program in which treatment decision to made during the same visit in XYZ tuberculosis treatment campaign? The answer is E, expert, MTB, and RIF ultra. This is key of MCQs. This is our YouTube channel. all the postgraduate presentation are uploaded here. Thank you very much.
Thank you very much, Dr. Sen. This is very important presentation. There are very important strategies